I am not able to hear the music, or it is muted.
No, sir, music is not there. Still, we are going live.
Okay.
Neha started.
Yes, good evening all. A very good evening to all the respected dignitaries, seniors, colleagues, experts on Zoom as well as YouTube Live. Welcome you all on behalf of Maharashtra Academy of Pediatrics and Maha-IP Women's Committee for today's program of Tuesday Tea. I, Dr. Neha Singh, Maha-IP Women's Committee co-chairperson and practicing pediatrician from Navi Mumbai Raigad district, as well as my co-host Dr. Swati Patil, Secretary, IAP Yavatmal and Zonal Member of Maha-IP Women's Committee from Vidarbha Zone. We both are moderators for today's Tuesday Take. Friends, we all know Tuesday Take is a unique concept program with topics of daily OPD practices. And here we have 5 speakers from different zones of Maharashtra, allotted with 5 different topics, 8 minutes for each speaker to present. And today we have 2 experts for guidance who will give their expert opinion after each topic. Viewers, please note today's program has been allotted 1 MMC point. So requesting everyone to please type your name, city name, central IIP and MMC registration number in the chat box. Now I welcome and request our Maha-IP President, Dr. Ramakant Patil sir, to kindly give his blessings. Over to you, sir.
Thank you, Neha. I must congratulate this women committee for having a consistent effort and choosing the towering personality of pediatric neurology as an expert for today's Tuesday Takes. And everybody in pediatrics knows Dr. Shefali Gulati ma'am and Dr. Lokesh Lingappa. And I also congratulate them for taking the different young neurologists from different part of Maharashtra, like Dr. Nikhil, Dr. Pankaj Rathi, Dr. Zabin, and Dr. Anup, for enlightening us on this muscular dystrophy and myopathies, and to have representative of we common pediatrician generalist. Dr. Jagruti is going to be there. How we elicit history, because this patient most of the time land with the pediatrician generalist and then they are sent to pediatric neurologists. We have got our homegrown towering personality as a guest of honor, Dr. Vasant Khalatkar. And this is a really wonderful activity. The consistency is really appreciable. And every program, we are having more than 200 to 50 viewership. And with consistency, our CIP EPs, Dr. Jitendra Gawane, our past vice presidents and convener, Dr. Jay Bhandarkar, and all many dignitaries, in spite of the busy schedule, in spite of the season fortunately going on, or unfortunately, I don't know, but the work has started for last 1.5 months. Still the consistency is there. And I will again congratulate the Women Committee, ably led by Dr. Sonali Shirbate and ably supported by Neha, Swati for today's program, Manjusha, Shilpa, Dr. Pallavi, Dr. Sonal Patil, Sucheta ma'am, Grivita, Nivedita, Dipti, and Mangai Sinha from Women's Committee. If please forgive me if I have forgot any name. For brevity, I am not taking names of all, but I am really it's a heartening experience to have such a wonderful, consistent programs from Maha-IP and particularly from Women's Committee. There will be formal introduction of Dr. Shefali ma'am and Dr. Lokesh, but we are really lucky to have this towering personality to guide the young neurologist and give us take-home message. Over to you, Neha and Swati.
Thank you, sir. Now I request our dynamic Maha-IP Secretary General Dr. Amol Pawar sir to please share his views. Over to you, sir.
Thank you, Neha. I have some sore throat because of a lot of conferences. First of all, I welcome all the dignitaries, Dr. Vasant Khalatkar sir, Dr. Jitendra Gawane sir, Dr. Jay Bhandarkar sir to this webinar. I thank Dr. Shefali Gulati ma'am and Lokesh Lingappa sir So for accepting to be as an expert to guide our young neurologist and to give some academics to all MAHAIP members. And I also congratulate all the women committee members, Neha, Sonali ma'am, Manjusha ma'am, and all the wonderful ladies. Dr. R.D. sir just now have taken all the names, so I won't repeat. And I will request Dr. Jitendra Gawane sir, who is Central IIP member from MMR region, to have few words. Please, Jitendra Gawane sir, over to you.
Good evening, everyone. We are witnessing the woman power of Maharashtra doing excellent work over consistently since last 2 years, and the new committee carrying over the work led by the founded by the previous committee, and I hope this this will continue for years together, and bringing the experts like Gulati madam and Lokesh sir brings the flavor of the topic. So let us, without wasting time, let us give the mic to Neha. So Neha,
1 minute, just I forgot to mention. I welcome Dr. Suhas Patil sir, who is MMC observer and senior pediatrician and a professor from Government Medical College, Nasik. Welcome, Suhas Patil sir. Over to you, Neha, now, please. Continue.
Thank you so much, sir. Yes, we welcome our MMC observer for today, Dr. Suhas Patil sir. Now I request our guest of honor, Dr. Vasant Kalatkar sir, to say a few words. Sir is a chairperson of infectious diseases IAP chapter. Welcome, sir.
Good evening, everyone. First, I want to congratulate Women Wing of Maharashtra IIP. Actually, I was really surprised how come it's possible for all these women to go for academic today. I know this is the 5th of Mangalwar for Mangala Gauri, and you all are all very busy. And in spite of then, I thought, no, these are the ladies. This is the woman power which can balance academic, home, social life, and everything, and their clinic also. So I once again want to congratulate you all. I will tell about neurology chapter. Last year I took neurology chapter as a chairperson, and before that Dr. Shefali was there, and before that Dr. Lokesh Lingappa, and then this after Lokesh Lingappa I was secretary for Dr. Lokesh Lingappa. Then this chapter started writing. Initially it was 200 members, then now it becomes a 700 member, and this in this last 4 years. Now chapter has attained such a good height. You saw that Agra conference, now next conference. Well, this all because of possible person like Dr. Shefali Gulati and Dr. Lokesh Lingappa, definitely. So I really want to thanks both the speaker of today that you have given time and you are there. Again, I want to thanks MAHAIP, Women Wing, and all our delegates who are consistently there. I'm looking after that more than 100 delegates are there. So really, this our MAHAIP gaining height and height. I wish all the best to MAHAIP. Thank you once again. Thanks for calling me.
Thank you so much, Vasant sir. We are fortunate to have with us 2 experts, and our first expert is Professor Shefali Gulati ma'am. She is Chief Child Neurology Division, Department of Pediatrics, AIIMS, New Delhi, President, Association of Child Neurology, India 2023-25, Faculty in Charge, Center of Excellence and Advanced Research of Childhood Neurodevelopment Disorders, President of Academy of Pediatric Neurology, Delhi. Ma'am has indexed 405 publications, more than 570 abstracts, and invited for more than 550 talks. Her area of specialization is autism, epilepsy, neuromuscular disorders, cerebral palsy, other NDT, neuro rehabilitation, and neuromodulation. Ma'am have received more than 15 international and national awards. Our second expert is Dr. Lokesh Lingappa sir. He is MD Pediatrics, DM Neurology, MRCP CH UK, Fellow in Pediatric Neurology, from Bristol, UK. He at present, sir, is Clinical Head Division of Pediatric Neurosciences, Consultant Neurologist, Child and Adolescent at Rainbow Children's Hospital, Hyderabad. His area of interest is critical care, neurology, and stroke. I welcome both our experts. Now I hand over to my co-moderator, Dr. Swati, for the further proceedings.
Yeah, thank you, ma'am. Myself, Dr. Swati Patil, extend my warmest welcome to each and everyone present here, all the respected dignitaries, our today's expert, and today's speakers, and all the attendees present here on Zoom and YouTube. On behalf of Women's Wing Maha IP, to a very super popular Tuesday Text program. With due permission of respected dignitaries here, we'll move to start with the first lecture. So I request, our today's theme is muscular disorders. And for that, I invite our first speaker, Dr. Jagruti Sanghvi Madam, on the topic history taking in muscular disorder. She is pediatrician from Mumbai and she is consultant at Nanavati Max Super Speciality Hospital and Advanced Multi-Speciality Hospital. Over to you, Dr. Jagruti Sanghvi Madam.
To Maha IP for giving me this opportunity to talk in front of so many eminent pediatric neurologists here. I would like to share my slides with all of you. I hope this is something that you can see. I'll talk about history taking in muscular disorders. That like medical history taking is one of the most important aspects.
Jagruti ma'am,
Yes.
Jagruti ma'am, your voice is not coming properly. It's a breaking and it's not proper.
Just a second.
Is it, Neha?
Yes, sir.
Am I audible now?
Yes, clear.
Yes, please.
Okay.
Yes.
Sorry. I'm going to share my screen again. I'm so sorry for the.
No problem, ma'am.
Am I audible, sir? Am I audible?
You are audible.
Yes,
You are
yes, ma'am.
audible.
Yes, ma'am.
Please
You
go
can
ahead.
I'm
continue.
sorry for the technical issues. Okay. It is said that whenever we have a patient who comes to us, one of the most important aspects of trying to figure out what's wrong is history taking. And this statement by Albert Einstein tells us a lot about what history taking, medical history taking is, that if I were to solve a problem and my life depended on it, I would use the first 55 minutes just determining the proper questions to ask. So my talk is all about trying to figure out the right questions to ask parents. It is said that neuromuscular disorders essentially defines the disorders of a motor unit and excludes the influence on the muscle fibers by the brain. So it clearly rules out patients who come to us with spasticity and a brisk deep tendon reflexes. The motor unit, as we all know, has 4 components. The first component is anterior horn cell or motor neuron, either in the brainstem or in the spinal cord. And typically the diseases that we come across are SMA and poliomyelitis. Then we have its axon, and multiple axons make up for the peripheral nerve. And typically diseases that we come across is Guillain-Barré syndrome or AIDP. Then we come to neuromuscular junction, and the diseases that we present to us are diseases like myasthenia gravis or botulism. And finally, the diseases of the muscle or the muscle fibers itself, which could be in the form of either myopathies or it could be a muscular dystrophy. So this is the motor unit, and our topic today is going to concentrate on these. Now, what are the chief complaints that the patient may come to us with? And what are the questions I would ask further to find out as to which part of the motor unit is the patient presenting with? First and foremost, I would like to know the onset, duration, and progress, which is what we all ask always. First is the age of presentation, whether it's a neonate, a child, a teenage, adult, or in the Sorry. Yeah, so a lot of times we are basically asking about onset, whether the onset is in acute, that is in days to weeks, or whether it's chronic in months to years. Duration, whether the patient is presented over days, weeks, months, or years. Whether it's a episodic illness or a progressive illness, and if it is progressive, how fast is it progressing? Is it getting worse, or are there episodes where the patient is getting better? When we ask about weakness, as to if the patient is presenting with weakness, it is very important to know the anatomic presentation or distribution of the weakness. So whether the arms are affected more than the legs, because there are certain conditions like scapulohumeral dystrophy, which may come with arm presentation more than the legs. Whether it's a proximal involvement of the muscles, which is seen more in cases of myopathies, or it's a distal presentation, which is seen more with the neuropathy, symmetric as we see in Guillain-Barré syndrome, or asymmetric as we see in poliomyelitis. Then we want to try and find if there are any presence or absence of bulbar involvement, like if there is any issues with chewing, swallowing, speech, which is what we could see with conditions like myasthenia gravis, ALS in older patients, etc. Then whether the weakness is fluctuating. So we all know that in myasthenia, as the day progresses, the weakness will become worsened. Whether there is any focal wasting, which you would see with conditions like neuropathies, where the nerve which is feeding is affected and therefore the muscle goes into wasting, or whether there is hypertrophy of muscle groups like we see in muscular dystrophies, whether there is fatigue, whether there are muscle cramps. So if you have cramps at rest, these are usually seen in benign conditions like restless legs, etc. Or if it is on exertion and relieved by rest, it could be seen in conditions like dystrophies. Then you have muscle pain seen with myositis, that is inflammation of the muscle, or any involuntary movements, fasciculations, especially seen in the tongue, like you see with anterior horn cell diseases like SME. Or is the patient having any kind of a sensory loss? So that is seen with neuropathies. Coming to gait characteristics, patients may come with toe walking, or they could have a Trendelenburg's gait, or they could have an exaggerated lumbar lordosis. And it's very important to know that if there are any other family members who are also having an exaggerated lordosis. Functional difficulties is something we need to ask for to kind of predict as to what is the amount of disability that the patient is having. So ambulatory distance, how much is the distance that the patient is able to walk, or the frequency of falls while walking, transition from the floor to standing, and we know about the famous Gower sign that we see in Duchenne's muscular dystrophy, difficulty in climbing stairs, combing of hair, reaching overhead. So that is all seen with proximal difficulties or proximal myopathies, dressing, undressing, buttoning of the shirt, seen with distal muscle involvement, running. If the child has been in sports and suddenly is not able to, then it's a huge disability for that child. Now, we also need to find out what has caused this and are there any complications that we are looking into. So we should ask for history of any viral infections like measles, mumps, chickenpox to look for conditions like myositis, or we could be also dealing with a past history of a respiratory or a diarrheal disease and therefore causing GBS. And the same is the case with history of vaccinations that are done in the past 6 weeks period. Also, we need to find out any factors that are helping or worsening the symptoms. Any recent respiratory infections or pneumonias, both from a cause perspective as well as from complications, because if respiratory muscles are involved, there's a high chance of aspiration and pneumonias. Cardiac symptoms like dizziness, syncope, chest pain, suggestive of some kind of myocardial involvement, giving us a clue as to which kind of muscular disorder it could be. History of dark-colored urine and hematuria seen with myoglobinuриas. And finally, you could have bulbar involvement seen with feeding and swallowing difficulties. Of course, it's very important to look at diplopia or ask for it, because extraocular muscle involvement seen with myasthenia gravis could be picked up in these patients. A developmental history is never less important in pediatrics, where we try to ask for milestones. So right from every detailed aspect of motor milestones, the head holding, to standing, to sitting without support, to walking without support, we need to go into details, including speech, because if the facial and the bulbar involvement is there, then speech is going to be delayed. Plus, some of these disorders could be a part of a generalized genetic disorder, which could also cause a global developmental delay. Coming to learning disturbances. Now, this can be seen with children who are suffering from these disorders, and therefore it causes them learning disabilities, restriction from doing their day-to-day or school activity. So the school performance could also be going down, and that raises the disability factor of this child, which would eventually help us in generally taking care of an overall multidisciplinary approach towards the child, so as to get the child back to the best occupation that is possible for him or her. Coming to a birth and perinatal history. A pedigree chart is very important. So at least a 3-generation detailed pedigree chart, including history of consanguinity or not, is very important. Religion is important for certain disorders where you would find a genetic predominance. In antenatal history, it is important not to know just whether there was a fetal movement, but the quality of the fetal kick or the quality of fetal movements also play a very important role for us to understand whether there has been a congenital myopathy or not. Coming to perinatal complications, if the child has a neonatal issue, neonatal SMA or whatever, the child may require resuscitation, may come out with a poor cry, a poor feeding history would be there. There might be a need for going on to the ventilator in congenital myopathies. The child could have respiratory distress. And of course, any relevant details regarding any other siblings who could have suffered from similar neuromuscular disorders or any other genetic conditions which could eventually corroborate or help us in our diagnosis. Apart from this, any other pertinent history also becomes important. So immunization of primary doses, boosters, the side effects related to it. As we all know, I just mentioned about GBS, could be seen with certain vaccinations as a post-vaccination GBS. So that is something to keep in mind. And there could be patients with poliomyelitis following a vaccination history. Then coming to a past history of any significant diseases, any hospitalizations, any pneumonias in the past, or being on any steroid treatment. So while we are talking here about genetic conditions causing myopathies or muscular disorders, there is a host of endocrine and drug-related myopathies that we need to keep in mind, like thyroid or hypothyroidism. We need to think about hypokalemia in certain patients, and children being on long-term steroid treatment could also have steroid-related myopathies. Family history of similar illness in any family member or siblings is important. Dietary history is important because nutrition is also going to form one of the core elements from the treatment aspect of these patients. So when we look at patients eventually in their treatment, nutrition forms one of the core pillars for the betterment of the child. So duration of breastfeeding, weaning, and calorie and protein intake becomes important. And finally, the socio-economic history regarding parents' education, size of the family, and financial affordability, because these are the patients who are going to require multidisciplinary team approach, will require genetic diagnosis, may require to be in the hospital in and out, and will require a lot of supportive treatment. And therefore, one needs to know the financial aspects of that particular family. And finally, don't forget a handshake with the mother. And I would like to show this small video where at the end of our history taking, if we just manage to do a handshake with a mother, then you might be able to pick up a case of myotonic muscular dystrophy, which might show a grip hypotonia in the mother. So this is a mother who has had a firm handshake, and following the handshake, because of myotonia, that is difficulty in relaxation of the muscles, you may not be able to, the mother is not able to completely open up her arms. There's a delayed relaxation. This is similarly seen by focusing on the thenar eminence, and that is showing again a difficult relaxation. So that ends my video here, and also ends my talk. So thank you. I think this is all I can think of as a pediatrician to ask from my patients, and I would like Dr. Shefali to give her expert comments on this.
Yeah, thank you, Dr. Jagruti Sanghvi Madam, for such a very well-structured presentation. Now, I will request our today's eminent expert, Dr. Shefali Gulati Madam, for her expert comments for the same.
Thank you, Swati. I think Jagruti has presented really very well. And, even now in 2023, history taking is very important. And we have to understand this. The role of clinician is still very important. And you need to do a detailed medical history and followed by a physical examination. And very importantly, one more important way to, to analyze these cases would be to think of all the neuromuscular disorders as having an anterior horn cell involvement, nerve involvement, neuromuscle junction involvement, and the muscle fiber involvement. These are the 4 parts of the motor unit, and something can be coming from the centrally also. That has to be kept in mind. And whenever as a clinician you see a suspected neuromuscular disorder case, it is very important to see in your making in your mind the flow of the thoughts, that it's whether proximal weakness is predominantly there or distal weakness. Because if you have distal weakness and then you would see for reflexes which are absent and muscle atrophy, then you think of a neuropathy and a nerve disorder. And otherwise, if proximal weakness is there and then you have absent reflexes and you have tongue fasciculation or a polymini myoclonus, then you will have an anterior horn cell involvement with a relatively static course. And as very rightly, it was pointed out that, you have to think about fatigability, because there may be prominent ptosis and a fatigability which may be there, which may be pointing towards a neuromuscle junction disorder. And in the otherwise a muscle disorder will have a relatively preserved reflexes with some maybe a weakness. I also want you to remember that whenever you're talking about fatigability and the fluctuations of weakness, it may not be only in diurnal. In certain situations, they have some kind of we have some syndromes, myasthenic syndromes, and you have a presentation like limb girdle myasthenia, that's called a limb girdle myasthenia gravis. So you may have fluctuations over days to weeks also. So I'm just telling you to that, keep in mind. And if anything is involved from the central side, you may have reflexes which are normal or brisk. You may have associated seizures, dysmorphism, and in a neonate, you may have poor feeding, lethargy, and a poor motor reflex. And one should understand that sometimes you may have a mixed picture, especially in the cases of a floppy child. You may have both central and peripheral causes. And in the proximal causes, we did talk about the SMAs. Then you have this muscle dystrophies with progressive involvement, with calf hypertrophy, which may be there. Neuromuscle junction wala, we have already spoken about the fatigability part. And then you may have, inflammatory picture can be there if you have some systemic features and rash. And you should ask about episodic worsening, and something may be related to diet, exercise, and all, keeping in mind metabolic. And when you have a relatively static course is the myopathic ones, which will be in a separate thing, separate talk, which will be the third and fourth. But one should always keep in mind, whenever you are having a child with suspected neuromuscle weakness, the age at onset, what is the clinical pattern, the functional as well as anatomical in the motor unit. Any involvement outside the skeletal muscle can give you some guidance. Disease course, the mode of inheritance is very important. We in the busy clinics forget to take the history, and you should have at least 3-generation history taken, which will guide. And then we have to think what are the means of securing a diagnosis and treatment options. So I think it has been really well thought of and well presented. And history taking still becomes the first step to look at, go ahead and analyze a case with a suspected neuromuscular weakness. I think I hand it over back to you, Dr. Swati. It was very nicely presented, and keeping a mention of the myotonia, which is important because, and especially even in neonates, if you're suspecting, you have to do the mother's thing, and the child examination will not give. That was something very important. And one more thing, you may not get a history, a family history in neuropathies. I just wanted to mention that in those situations, when you are saying that there's no family history of something like a neuropathy, you should need to examine the family members. You may not have any symptoms, but you may have signs. So when you are going to rule out a family history of neuropathy, that does not only include asking a history of neuropathy, you need to examine the family members. So these are some important things, and always keep looking at the motor unit and how you want to go about doing it. History is most important. Even examination will be tailored and guided depending on what you are seeing. So, I mean, that's very important. And for pediatricians, we do have a app, in which we had made a tool that was targeted for the pediatricians, which is for the neuromotor impairment that we had made during the England study, and that we had wanted to distinguish the cerebral palsy from neuromuscular disorders, from post-meningitis and post-stroke, post-encephalitic sequelae. And in that, you have that the tool which was modified by AIMS, and later on, it's from 1 month to 18 years, and you can download it from the Google and Apple Play Store, and it is called Ped Neuro AIMS Diagnostics, PED for pediatric, NEURO Neuro, AIMS AIMS Diagnostics. It has also actually 4 apps. It is got for autism, ADHD, neuromotor impairments, and epilepsy. So they all can be helpful for all the practicing pediatricians. You just put the age of the child, you get the 8 sensitive questions to ask and observe, and then you will get the algorithm running in the background, because we don't have time in the outpatient, so busy to keep on having performing and all that. And I think with autism and all also, it can help if you're seeing patients in the outpatient. Swati, hand over to you.
Thank you, ma'am, for such informative comments. Now, I will request our today's another expert, respected Dr. Lokesh Lingappa sir, to have his expert comments for the same.
Lokesh sir.
Sir, I think Lokesh sir once again logged out.
Okay, I will call him. Continue. Swati, continue. Please continue second.
Okay, sir. Okay. So our today's next speaker is Dr. Nikhil Pawar sir. He is pediatric neurologist from Nashik and director of Vidya Vikas Pediatric Neurosciences Center, Nashik. Sir is going to talk on muscular dystrophies, DMD, BMD, its clinical features, diagnosis and treatment. So I will request Dr. Nikhil Pawar sir to start with the lecture.
Good evening, everyone.
Presentation. Yes.
Thank you so much for this opportunity. And after moving on with this history taking session,
Dr. Nikhil sir, you are unmuted.
yes, am I audible now?
Yes, sir. Yes, sir. Please continue.
Yeah, sorry. So one of the most common muscular dystrophies which we are going to discuss today is Duchenne and Becker's.
Sir, kindly share your presentation.
Am I audible now?
Yes.
You are audible, but presentation. Nikhil.
Yes. Okay. Are the screens, is it visible now?
No, sir.
No.
I think there is a glitch here. Is it still not visible?
Sir, you are sharing entire screen. Just click on the presentation window. You are sharing the entire screen of your laptop. While sharing, only click on the presentation.
Sure. All right.
Yes, sir.
Pallavi
It is,
ma'am,
yes, sir. It is visible now. Please go
Okay.
ahead.
Pallavi ma'am,
Oh,
Okay.
sir.
please admit Lokesh sir.
Yes, sir.
All right. Am I audible, ma'am?
Yes, sir.
Yes,
Please.
yes, you are audible and your
Yeah.
screen is visible, Nikhil. Please
Sure.
continue.
So sorry for the glitch. So as we are talking about extreme recessive, it's one of the commonest disorder seen in 1 in 5,000 male births, which is a severe progressive muscle wasting disease and has a difficulty in movement, needing for assisted ventilation and can cause premature death. The problem here is in the mutation of the DMD gene, which can reduce the production of dystrophin in the muscle. So the various dystrophinopathies which we have is DMD, which has a more severe clinical symptoms, whereas BMD has a milder clinical phenotype, whereas there is an intermediate phenotype which has one of the outliers called mild DMD or severe BMD. The last one is the DMD associated dilated cardiomyopathy, where the heart is primarily affected and the skeletal muscle is spared. As you see in this chart, the phenotypic variability is because of the dystrophin percentage present in the Duchenne, which is less than 5%, whereas in Becker's it's more than 20%, leading to the more benign course. So when do we suspect DMD? After the clinical examination and history, after clinical history, if there is any delayed motor milestones in a male child, you should suspect DMD, along with presence of Gower sign, slow walking, calf hypertrophy, and if there are unexplained increases in transaminase, you should think of DMD. Another clinical features would be like frequent falls, learning disability, speech delay, language, autism, ADHD, and short stature. These could also be pointers towards DMD. Clinical examination, the most famous Gower sign, where the child uses his hand to push on the legs to stand up. Gore sign can also be seen in other dystrophies, along with some discitis and juvenile idiopathic arthritis. Another famous sign is a Valley Pradhan sign, which is very helpful in diagnosis of DMD when you do not have a calf hypertrophy. And we can see that two, it's a linear depression is because of the atrophy of the axillary folds, and the hypertrophied infraspinatus and deltoid muscles forms the two prominent mounts. And the third sign is a Marion sign, where the patient slips through the examiner's grasp when he is lifted under the arm. So there are various stages in the DMD. The stage 1 includes a pre-symptomatic, where there is only high CK levels, whereas early ambulatory, we can see the Gower sign, the waddling gait. In the late ambulatory, the child cannot climb stairs, and in early non-ambulatory, the child is dependent on wheelchair. The stage 5, which is the late non-ambulatory, there is limited upper extremity function. So while approaching the diagnosis, when we have elevated CK and the clinical findings suggestive dystrophinopathy, we should straightly head for DMD gene mutation. So step 1 includes MLPA for large deletions and duplications. And if we don't find any, we have to proceed for a next generation sequencing, which is the whole exome sequence, to detect point mutations and micro deletions and duplications. If both these gene tests are negative, then muscle biopsy is useful for dystrophin analysis. Again, as in the chart, we can see MLPA helps in detecting most commonly around 75 to 80% of deletion duplication analysis, whereas whole exome sequence will detect the other 20 to 35% of micro deletions. So what makes BMD different from DMD is the in-frame and out-frame deletion. So as you see here in the exons 47, 49, and the 48 exon is missing, but the 47 and 49 can be attached to each other because of the in-frame structure, and still a protein can be transcribed and formed, which is partially functional. Whereas in DMD, if you see the exon 46 is absent, but 45 and 47 are out of frame, they cannot combine, and then there is a stop codon, and then no dystrophin is formed, leading to the severe phenotype of seen in DMD. So the closest differential is limb girdle muscular dystrophy. the distinction between these two is difficult, and the calf muscle hypertrophy is not so striking in LGMD. If you have a negative genetics for DMD, we should test for FKRP gene mutation, which is LGMD2I type for the diagnosis. Another closest differential is Emery-Dreifuss muscular dystrophy, and the pointers towards it is the classical contractures and humeroperoneal pattern of weakness. The third differential is a spinomuscular atrophy of type 2 and type 3, which usually we call them as sitters and walkers, seen from 15 months of age till adulthood. The differential pointing factors are diffuse reflexia, tongue fasciculation, and neurogenic EMG pattern. Coming to the treatment part, we all know it's prednisolone and deflazacort, and it is said to improve the strength and function and delay the loss of ability to walk. And the usual dosing is around 0.75 milligram per kg per day of prednisolone, and deflazacort is 0.9 milligram per kg per day. So coming to the next part of the medications is exon skipping medicines, as we have earlier discussed. So let's say this is a dystrophin protein with all these exons in line, and we need all the exons for a complete functional protein. And if we see the exon 50 is missing, so 14 and 51 exons with their opposite ends cannot connect to each other. So what the exon skipping medicine does is it removes the exon, which is like, let's say in this case, exon 51, and it helps to connect exon 49 with 52 to form a shorter form of dystrophin protein. And at least we can get some partially functional protein. So this is the mechanism of exon skipping medicines. And these are the list of FDA approved exon skipping medicines as per the year. In June 2023, a new drug, Elevidys, has been introduced, which is the first gene therapy. Is approved for ambulatory patients between 4 to 5 years, but not for patients with exon 8 and or 9 deletion. Monitoring also becomes important in these patients. So at every as a baseline diagnosis, we need to also perform ECG and echo, and annually we have to perform ECG to look at the cardiac status. In the labs, we have to, at the baseline, the first diagnosis, we have to perform the calcium profile, and every year we have to perform vitamin D calcium profile and X-rays. It's very important that every clinical visit, we have to ask for any presence of back pain or fractures, especially when the child is on steroids. And third, that every 6 months, the child needs to be assessed for his height and also for the puberty until the child has attained a full height. So the take-home message here is any motor delay in a male child should prompt for a CPK. Unexplained elevated transaminases or toe walking in a male child are early clues for DMD. Start oral corticosteroids early in the early ambulatory phase so that it might help prevent the scoliosis and maintain the respiratory function. As the gene therapy is now available, prompt and early diagnosis becomes more important. And I think efforts should be made to include DMD in the newborn screening, because these newer emerging DMD therapies will be proving more effective. And if we are starting them early, it will be of good effect for the patient clinically. These are my references. Thank you so much.
Thank you, sir, for such a compelling presentation. And now I will request our expert, Dr. Gulati Madam, to have her expert comments on this.
Yeah, it has been very well covered by Nikhil. And yes, you have an incidence of 1 in 5,000. And besides the spectrum, which is very correctly showed, there are three more which should be mentioned. One is a muscle cramps with myoglobinuria, and other is asymptomatic elevations of muscle enzymes and manifesting DMD, BMD carriers. Besides the DMD, Becker's outliers, and the DMD associated cardiac myopathy. And this is something which is very important to understand. And and he's very rightly talked about the in-frame and out-frame mutations. And one thing is there that there are a lot of it's a very big gene, and it has a lot of mutations which are there, and only some of them are amenable to the neotherapies, which has been mentioning, because it can be either due to the deletions or it can be sometimes insertions, and you may have a stop codon which is there, which causes the nonsense because of nonsense mutation. And basically the problem which are occurring in DMD, to realize that it is not only the dystrophin nutrient deficiency which is there. It is also the ongoing oxidative radical damage and inflammation, because of which, you know, you have the steroids, which are very important, which is going to reduce the, the inflammation and oxidative radical damage. And that's why it's going to reduce the fibrosis and regeneration. And that's why they are standard of care. This is something very important to understand. And you have various patterns of distribution in the body, which can, you know, suggest for the DMD is basically pelvic girdle, and you have proximal more than distal, and lower limb more than upper limb, and neck flexors and enlargement of calf. And yes, very rightly, you have differences of LGMD, EDMD, FSHD, and dysferrinopathy, to name a few. Just remember that this hypertrophy, what we see in Duchenne muscle dystrophy of the calves, is basically a pseudo hypertrophy. And that is because it's replaced by fibrofatty tissue. And it is seen in around 4% of patients of DMD. The Gower sign, very classically described, is because of weakness of the hip extensors and gluteus maximus and quadriceps. And yes, in sarcoglycanopathies, you know, we have Dr. Khadilkar had described basically an hip abduction sign because of splaying of the thighs while getting up from squatting position, and that was for the sarcoglycanopathies. For Gower sign, I just wanted to mention one thing, that, you know, there is something like a Gower sign is something like a modified Gower sign. Gower sign classical has been getting in upright position from a supine position, which we do not do. We do it from sitting position. So that is a modified Gower sign, which we do in getting in upright position from a squatting or a sitting position. But some texts have described that Gower sign in sarcoglycanopathy could be because of the, you know, the one which is talking about what Dr. Khadilkar had said of the hip, the abduction sign. Some of the literature talks about that as a modified, but classically the modified Gower is what we are actually doing, and the complete Gower is what you're doing from a supine position, which we generally do not do. And you should take the time, a Gower's maneuver time, to see the fall of the child, you know, how much time the child takes from sitting to standing position. And that will be important. And a valley sign, which was suggested by Dr. Sunil Pradhan, has been very rightly said. There is also scapular winging, which may be a asymmetrical point towards facioscapular humeral dystrophy. And, you know, they also have it many in LGMD, scapular winging, which is caused by weakness of serrator, anterior and trapezius. And also something interesting is this calf hypertrophy is because of deposition of fat and connective tissue, which is giving this term pseudo hypertrophy. But, you know, when you were being talked about the valley sign, where you have deltoid and infraspinatus, which are hypertrophied, which are mounts with a fasting of the posterior axillary fold, which is the valley. And you also have tongue hypertrophy in this. So basically, you know, there is some areas, there is some, you know, there's some areas of differential, some groups of muscles are atrophied and some are hypertrophied. This should be coming to your mind as interesting, you know, and there is no clear reason for this, but there apparently appears to be differential expression of various proteins in the various different muscle groups. That is why, you know, you have seen that muscles that are used heavily in utero and early in life, such as the tongue, diaphragm, and limb flexors, they get involved early and then they will have a problem later on. So basically, there has been a differential thing, and it's being postulated that you may have, these differential hypertrophy and hypertrophy in these patients. And in a cohort of patients in India, it was shown that calf hypertrophy was in 93-94%, and TA contractures, which we see because they have a lot of common toe walking, is in 70%. And the winging of scapula can be in around 1/3, and kyphoscoliosis will be around in 11-13 patients. And we have to look for cardiac involvement and pulmonary functions, sleep disordered breathing, very important to be seen in these patients. Also, that there may be smooth muscle dysfunction in the form of problem for the bladder from the GI muscle, problem for the blood vessel muscle, which we have shown. 30% may have intellectual disability, and they may have, 1/5 may have ADHD, behavioral problems, depression. So there are many things, and SLD has been shown in certain mutations of downstream to the exon 45, and sometimes association with the ASD, autism, has been seen. So it is very complicated, and the treatment options which have come up, just remember that you have currently exon skipping for 51, which is the maximum evidence, then 53 is lesser evidence, and 45 is the least evidence as of now. And you you have this gene therapy which has come up, but remember that these are all and then you have atalurin, which is a exon skipping. So, sorry, which is a stop codon read through. And these exon 51 skipping one is eteplirsen, and then you have vitulursen as 53 exon skipping, and 45 is goldirsen. And the atalurin is a stop codon read through. So all 4 of these which are available will correspond to around 40 to 45% of our patients. So we should see the genotype, and then you have tables which are available in which, you can see whether any particular kind of gene combination, the genetic defect combination is going to be helping you to do it. So first you have to do an MLPA, and if the MLPA is negative, then we go ahead and do the whole exome sequencing, and that is how we will, most of the times, the stop codon, the nonsense mutations you get picked up only on a whole exome sequencing, but mostly you get picked up by the MLPA. And steroids and multidisciplinary supportive care in the form of care for the bone health, in the care for the respiratory, cardiac, all these have to be kept in mind and followed up closely. And those newer therapies are really expensive for a 30 kg child. All these therapies will cost, exon skipping ones will cost around 5 to 8 crores per year. And the gene therapy which has come up is more than $2 million US. And the gene therapy also is still certain more studies are required. And why the exon 8 or 9 ones are excluded? Because there is a hinge which is there, which has been there on exon 8 and if you don't have that in that particular patient, then gene therapy cannot be used. So you do have a diverse, and dystrophinopathies are most common, and we need to understand, and you will be seeing them very commonly in your practice. Over to you, Swati.
Thank you, ma'am. Now I will ask our today's other eminent expert, Dr. Lokesh Lingappa sir, to have his expert comments for the same. I think sir is there now.
Yeah, I think extensively covered by the speaker and Dr. Shefali. I think with for the short of time, I think we should go ahead with the next speakers because it's going to get very late.
Okay, sir. Okay.
Okay.
So our today's third speaker is Dr. Pankaj Rathi sir. His presentation is on classify myopathies. Dr. Pankaj Rathi sir is consultant pediatric and adult neurologist from Narayana Super Speciality Hospital, Nanded. So I will request Dr. Pankaj Rathi sir to start with his presentation now.
Yes, ma'am. Screen is visible, madam?
Yes,
Yes,
sir.
sir.
Make full screen. Make full screen.
Full screen, yes.
No, it's there.
No, sir.
You have to go back.
So,
Sir, you have to go back.
1 second, sir.
You have to close this and then again share.
Sir, make it your presentation full screen. Stop sharing screen. I'm doing the stop sharing.
Please do, madam.
Make the screen full first, then share your screen, sir.
Is it there, madam? No.
I cannot see now, but it's coming, sir.
It's
It
coming.
will come.
Is it visible, madam?
No, not
Not
yet.
yet, sir.
Not yet.
Can you do it for me? Means, can you do it?
Yes, sir.
Pallavi ma'am, please.
Sir, just try once again.
Yes, I have clicked on the PowerPoint and now I'm sharing it.
Yes, sir. It's full
Perfect.
screen now.
Yes.
Please
Please
go
start.
ahead.
Yes. Thank you very much for giving me opportunity. This is the topic of classification of myopathies. So most of the topics are now covered. This slide is not moving, madam. So myopathies are heterogeneous groups of disorder which are primarily affecting the skeletal muscle structure or their metabolism or biochannel functions. So myopathies are broadly classified according to these problems. So these are the types of myopathies. These are the congenital myopathies, muscular dystrophies, metabolic myopathies, mitochondrial myopathies, inflammatory myopathies, endocrine myopathies, toxic myopathies, and in channelopathies, these are myotonic disorders and periodic paralysis. So coming to the congenital myopathies, these are classified first on the histopathological structure, like a central core disease, Nemelin myopathies, centronuclear or myotubular myopathy, fiber type disproportion myopathy, and other structural congenital myopathies. And according to the now the gene locus, in that congenital myopathies associated with protein accumulations, these are the Nemelin myopathies, CAP disease, zebra body myopathy, myosin storage myopathy. Then congenital myopathies which are associated with cores like central core disease, multimini core disease, and including congenital myopathy with cores. Then congenital myopathies associated with cores and rods, these are the core rod myopathy. Then the congenital myopathies which are associated with centralized nuclei, these are the myotubular myopathy and centronuclear myopathy. So normally in the muscles, the nuclei are peripherally placed. In these congenital myopathies, the nuclei are in the center. And then the congenital myopathies associated only with small type fiber 1, these are congenital fiber type disproportion. So there are type 1 and type 2 fiber. The disproportion is called as congenital fiber type disproportion. So coming to the muscular dystrophies. So muscular dystrophies are the inherited disease and there is progressive muscle degeneration. And the commonest, as we discussed, is the Duchenne muscular dystrophy and Baker's muscular dystrophy. And this can also happen in the females, and they can be the carrier, and they can be manifest more in patients with Turner syndrome and when there is a extra inactivations. Then there are the Limb-Girdle muscular dystrophies. They are further classified as autosomal dominant and recessive. And from the genetic, they are now classified as LGMD type 1 from A to D, and in type 2 from A to up to T. So this is the recent classification for limb-girdle muscular dystrophies. Then the congenital muscular dystrophies because of the glycosylation disorders. Then other congenital muscular dystrophies. Then muscular dystrophy secondary to nuclear envelope defects. Muscular dystrophy secondary to RNA defect, that is the triplet gene disorder like Duchenne muscular dystrophy 1 and 2. And muscular dystrophy secondary to unknown mechanism. These are the facioscapulohumeral and oculopharyngeal muscular dystrophies. So coming to the metabolic myopathies, our muscles require constant source of energy for functioning. So they use glycogen, and after that fats are used. And any defects in this storage or the energy substrate can lead to myopathies. These are the glycogen storage disorder, then fatty acid oxidation disorder, disorders of purine metabolism, and mitochondrial disorder. So these myopathies can present with severe muscle cramps, exercise tolerance, early fatigability. Then they can have a rhabdomyolysis, and they can have a contractures, and the patients with fatty acid oxidation disorders, they can even become quite sick. And these mitochondrial disorder myopathies, they can present with eye involvement, brain involvement, cardiac involvement, liver involvement, even GIT involvement. So mitochondrial disorders can present with ophthalmoplegia, heart defects, or muscle cramps, seizures. So there are a wide spectrum of disorders can present with mitochondrial disorders. So coming to the inflammatory myopathies, these are the idiopathic in that there are the juvenile dermatomyositis, then polymyositis, inclusion body myositis, myositis as an overlap syndrome, and other inflammatory myopathies. And in infectious, which is the most commonest cause of myopathy in pediatrics, is the viral myositis, commonly because of the influenza virus, can be because of measles, mumps, and other viruses. Parasitic myositis because of the trichinosis. Bacterial myositis usually happens in patients who are immunocompromised because of the Staph aureus, Streptococcus or Yersinia. And again, fungal myositis again happen in those patients who are immunocompromised. Commonest organism is Candida. Coming to the endocrine myopathies, So muscles are again affected by the endocrine disorders. They can be hypo or hyperthyroidism. The patients with hyperthyroidism are at risk of getting periodic hyperkalemic periodic paralysis, as well as patients with hypothyroidism, they are at the risk of getting the myopathy. So in children, they can get a calf muscle hypertrophy, and then can be a delayed tendon reflexes. So that is called as Kocher-Sebris muscular dystrophies. Then because of hyperparathyroidism, it can be because of vitamin D deficiency or renal failure. Then vitamin D deficiency, glucocorticoid excess either can be exogenous or because of endogenous cause, because of excess production of glucocorticoids, muscle weakness can happen. And patients with pituitary disorders like acromegaly or growth hormone deficiency or any mass which is sitting on the pituitary and causing its dysfunction. So all these disorders can also cause endocrine myopathies. Then channelopathies, these are the periodic paralysis and myotonic disorders of unknown mechanism, where there are the myotonic dystrophy type 1 and 2. And in chloride channel myotonias, there are the Thompson disease. In sodium channel myotonia, they are with periodic paralysis or without periodic paralysis, and possible sodium or potassium channel abnormality with periodic paralysis, and calcium channel abnormality with periodic paralysis. That is usually a hypokalemic periodic paralysis. So these patients can present with myotonia or paramyotonia. That is, with exercise, the muscle weakness, the stiffness decreases or improves. So there is myotonia and paramyotonia, and they can have a periodic paralysis. So patients with hyperthyroidism, they can get early morning muscle weakness, especially after over-exercise or taking a high carbohydrate diet, and they can have a periodic paralysis. The paralysis can last from hours up to days also, but they are usually correctable. Then the toxic myopathies because of the drugs. These are the necrotizing myopathy because of statins, labetalol, propofol, alcohol. Then the inflammatory myopathies because of D-penicillamine and phenytoin. Then mitochondrial myopathies, these are usually because of the antiretroviral drugs and zidovudine. And then the antimicrotubular myopathies because of the colchicine and vincristine. So these are my references. Thank you very much.
Thank you, sir, for such a lucid and captivating presentation. Now I will ask Dr. Gulati madam to have her comments on this presentation.
No, it's been presented really well. And I just want to mention that it is important to understand that when you are basically when you are going to be approaching a floppy child, then you have to go and think about whether, the most commonly we have to see certain differentials where you have SMA and, non-FIQ SMA, and then the congenital myopathies and all will come in the picture is important to understand. And we have to also understand that there is a considerable overlap which is there in congenital myopathies and congenital muscle dystrophies. There is a lot of overlap. And when you have because even the genetics, if you see the same genes, the defects in the same genes can cause either one of them. So there is a basically, certain features. If you have prominent facial weakness with or without ptosis, hypotonia, weak respiratory and bulbar muscle weakness, extraocular muscle may be involved sometimes. And all this may prompt to think about congenital myopathies in that situation. And whenever you have any BRIS reflexes, any CNS abnormalities, think of some central cause, and or some dysmorphism is there, any metabolic abnormalities. So you have to keep thinking about the differentials in those situations. And one thing also to remember that sometimes when you're distinguishing these congenital myopathies, radiogenomics do play a role, whether you are having certain involvements of the various muscle groups are there or not, will help you in guidance can be given. You can help get guidance to see whether certain posterior compartment is involved or the predominantly proximal involvement is there, tibialis anterior involvement. So that helps. So and that there is something called radiogenomics that with the help of radiology, it can guide you depending on which groups of muscle are involved, which genetics to keep thinking of. And also all these systemic symptoms which are there, extra muscle outside the muscle, give some aids to think about which specific myopathies which can be there. both in less than 2 years as well as more than 8 years. With the genetics coming up, it is actually revolutionized. Otherwise, in the past, we were always doing muscle biopsies, and the muscle biopsies were giving a lot of help to us in many situations, sometimes even on H&E, and because that sometimes even emeline rod can be seen on H&E, or you may have by other stains, specific stains, and even electron microscopy. So there were specific histopathological features which was guiding us, but now the genetics has taken over in a very big way. Just also wanted to mention that even for DMD as well as myopathies and other muscle dystrophies, they're trying to propose whether you can use skin biopsy, because you have a sweat gland of the skin biopsy, which is a rectal pylori, that can be also stained, and that can be stained, and that can may possibly replace muscle biopsy. We've had many papers on that, and also that whether an ultrasound of muscle, if somebody is interested, can actually learn. And you have specific, we've done some studies on that, and there's some specific eco texture which is there on, and there's some grades which are described. On that basis, you get some help, especially for hypotonic children, for congenital myopathy, CMD, and SMA, and we have found that it helps in that situation. And as of now, so you have suspected, then you think about whether the radiology helps, then the muscle biopsy and genetics testing becoming the gold standard. And basically congenital myopathy, congenital muscle dystrophy, and many congenital myasthenic syndromes, SMA, Pompe's, myotonic dystrophy, all will come in a differential spectrum from these situations. So, and other, inflammatory and all is covered. And I think that's a very good overview overall till now you've had of the various neuromuscle disorders by extensive research done by our learned colleagues.
Thank you, ma'am. Now I will request Dr. Lokesh Lingappa, sir, if he can add anything in for the same topic.
Quite extensively covered by Dr. Pankaj Jyoti and commented by Dr. Shefali. So I think as a pediatrician, one of the important things when you find an infant with hypotonia, things are not clear. Not all of them are element. You don't find fasciculations, not much of atrophy. Think of some of the treatable disorders. So there can be child with severe hypocalcemia, rickets, hypoparathyroidism or pseudohypoparathyroidism, and renal tubular acidosis. These can present similar to any other child with a element syndrome in an infant. So just doing a electrolytes, calcium, magnesium, phosphorus, and alkaline phosphatase in these infants before referring to a pediatric neurologist, you would be ruling out some of these treatable disorders where you can actually manage. Recently, we picked up a child with pseudohypoparathyroidism similarly, who was 10-month-old, who presented with floppy infant kind of presentation. I think those are things as a pediatrician you can do. Thank you. You can go to next presentation.
Thank you, sir. So our next speaker is Dr. Zabi Khan. He is practicing pediatric neurologist from Yavatmal and assistant professor in SVN GMC, Yavatmal. He is going to present on differential diagnosis of myopathies. Over to you, Dr. Zabi.
Am I audible?
Yes, sir, you are audible.
You are audible.
Sir, just make the presentation full screen.
One second.
Yes, sir, it is full screen. Thank you.
Okay, so good evening, everyone. Thank you for the opportunity given. My topic is differential diagnosis of myopathies. As most of the discussion on myopathies is done already, I would like to start with where a patient with weakness, whether a baby with a muscle weakness or a weak baby from birth usually presents. So how to approach that child and come to a differential diagnosis. So myopathies are a group of muscle disorders characterized clinically by hypotonia and weakness, usually from birth, and a static or a slowly progressive course. For arriving to a diagnosis, we should first be able to differentiate between different causes of muscle weakness and hypotonia. So first, we should be able to differentiate whether it is a upper motor neuron cause of muscle weakness, or it is a lower motor neuron cause. It is a CNS cause or a peripheral nervous system cause. And once the peripheral nervous system cause is established, then we have to differentiate whether it is neuropathy or a myopathy. Once we establish that is a myopathic cause, the syndromic approach to differentiate between different genetic subtypes of myopathies can be used so as to prioritize the diagnostic testing. So first, to differentiate between central nervous system disease and a peripheral nervous system disease, we all know that central nervous system presents with muscle spasticity or hypertonia. Patient may have a hemidistribution kind of weakness, and patient will have a hyperreflexia or clonus on examinations, and the cognition will be impaired, may be impaired, or he may have a delayed cognitive milestones and altered mental status, and pupillary signs are usually present in central nervous system, and if focal cortical signs are present. So these usually point towards a central nervous system disease. For a peripheral nervous system, child would be hypotonic and hyporeflexia, or suppressed reflexes will be there. And if at all, it can be associated with the dermatomal sensory loss, and significant muscle atrophy is there. And weakness is either symmetrical generalized weakness or very focal weakness in case of a specific neuropathy is there. So if such type of child present at birth, so it could be a congenital myopathy, or other differentials could be for a floppy infant or a weak infant. It could be either congenital myopathy or congenital muscular dystrophies, as already told, congenital myotonic dystrophy, congenital myasthenic syndromes, spinal muscular atrophy, Prader-Willi syndrome, or other metabolic myopathies, including Pompe's disease, acid maltose deficiency. So there are certain features which usually favors myopathies. So hypotonia, weakness, and hyporeflexia, and myopathies usually have a proximal weakness with reduced muscle bulk, and if there is a prominent facial weakness with or without ptosis, that goes towards myopathy, frog-like posture in a small baby, and weakness and dysfunction of respiratory and bulbar muscles, and extraocular muscles may be involved, and usually intact sensation and usually normal intelligence. These pointers usually point towards a myopathy. Some uncommon clinical features which point towards alternate clinical diagnosis: CNS abnormalities, like if the child is presenting like a hypoxic ischemic encephalopathy, but you have to keep in mind that certain myopathic babies also are predisposed to have a delayed cry at birth and may have a comorbid hypoxic ischemic encephalopathy at birth. Tongue fasciculation, which has already been said, which is suggestive of denervation, points towards spinal muscular atrophy. Presence of dysmorphic facies points towards metabolic and or central or syndromic cause of illness, but there could be myopathic facies in congenital myopathies. Extreme joint laxity points towards connective tissue disorder. And metabolic abnormalities like raised lactate or metabolic acidosis points towards metabolic conditions, for example, mitochondrial conditions. So once we are sure that this is a peripheral cause of weakness or hypotonia, so we should differentiate between myopathy and neuropathy. So this is very important slide, because we should be able to differentiate whether clinically whether the child is having neuropathy or myopathy. So site of weakness in myopathy is usually a proximal weakness, and neuropathies have usually a distal weakness, but there are certain myopathies which can present with distal weaknesses also. And sensory examination, myopathies are usually pure motor, and neuropathy may have concomitant sensory symptoms if sensory fibers are also involved. Reflexes are lost early in neuropathies, and they may be preserved till late, or they are suppressed in myopathies. Fasciculations are present in neuropathies. They are not typically in myopathies. Contractures may be present in myopathies. They are not usual feature of neuropathies. Myocardial dysfunction. Myopathies may have accompanying cardiac dysfunction with dystrophies like DMD and because they can have a myocardial. Also, emeritopus can also have a myocardial dysfunction, but that is not a typical feature of neuropathies. Atrophy of the muscle is usually present early in neuropathies, but complete atrophy may be absent, or late atrophy is present in myopathies. CK levels are elevated in myopathies, but they are normal in neuropathies. If you do a nerve conduction test, that will be normal in myopathy, but it will be slowed down in neuropathies. On EMG, myopathies will show a smaller motor units, but neuropathies will show a fibrillation and fasciculation pattern. If you do an MRI of muscle, then in myopathy, it will show enhancement of affected muscles, but near normal appearance in neuropathies. And muscle biopsy will show normal looking muscle in neuropathies, whether it will show irregular necrotic fibers and other types of patterns in myopathies. So now if we are up to this, if we are sure that the cause is peripheral nervous system, and in that also, if the cause is myopathies, we have come to this. So for the further differentiations, we should do for this clinical and evaluation, which will have a differentiating features between different types of myopathies and other conditions presenting with peripheral weaknesses. So first we have to look for positive and negative symptoms. Positive symptoms in child with weakness or hypotonia will be positive symptoms are classified as myalgia, cramps, contractures, and myotonias. And negative symptoms like weakness, fatigue, exercise intolerance, or muscle atrophy. We have to look for these symptoms, and accordingly, then we have to see for the so duration of evaluation and temporal duration, which was talked of in the first presentation, that had to be looked up. And if we have episodic periods of weakness with normal strength between the periods, then it points to our periodic paralysis or metabolic myopathies due to certain glycolytic pathway disorders, or it could be a constant weakness. So first we have to see whether the weakness is episodic or constant. Constant weakness can present as acute or subacute progression, chronic or slow progression over the years, or it may be non-progressive with little change over decades. If it is acute or subacute progression, it usually points toward inflammatory myopathies like dermatomyositis or polymyositis. For chronic and slow progression over the years, most of the muscular dystrophies have a chronic and slow progression over the years. And if it is a non-progressive weakness with little change over thickness, usually congenital myopathy is present this way. So we have to also see whether the episodes of weakness, either they are monophasic or relapsing kind of weaknesses. So usually polymyositis can have an acute monophasic course with complete resolution of strength within weeks or months. And a patient with periodic paralysis or metabolic myopathies can have recurrent attacks of weaknesses spanning over many years. So, and also the presentation, certain myopathies present at birth and certain will present in the later childhood. The commonly presenting myopathies presenting at birth are usually congenital myotonic dystrophy, myotubular myopathies, congenital fiber disproportion, central cord diseases, and lipid storage disorders, and the glycogen storage disorder will also present at birth. And myopathies presenting in later childhood are inflammatory myopathies like dermatomyositis or polymyositis, muscular dystrophies, congenital myopathies like Niemann-Pick or centronuclear myopathies, and mitochondrial myopathies. And there are certain myopathies which present at adulthood. We have to also look for the distribution of weakness. If it is a proximal limb girdle weakness, or distal weakness, or proximal arm or distal leg weakness, or which type of presentation the weakness has. Accordingly, we can differentiate between different types of myopathies that had been already covered as a type of weaknesses and their presentation. Usually, what I've said earlier is myopathies are usually proximal, but there are certain myopathies which present with distal weaknesses. It usually involves the distal muscles of upper or lower extremities, anterior or posterior compartment muscle groups, and it is usually symmetrical. Although distal weakness is a more common feature of a neuropathy, but certain myopathies can also present with distal weaknesses. For example, late adult onset distal myopathies, type 1, type 2, and inclusion body myositis. This can also present with distal weakness. Then there are other patterns of weaknesses. For further differentiation, we have to see the precipitating factors which have precipitated the weakness in the child. So if it is like if the weakness or contracture is precipitated by cold, it could be associated with myotonic dystrophy, or as already said, toxic myopathy or drug-induced myopathy. So we have to see for the precipitating factors whether the child is receiving continuous long doses of steroids. So that can also cause toxic myopathy. And episodic weaknesses with fever are usually in a carnitine palmitil transferase deficiency disorders. Cold exposure, as I've already said, it will precipitate the muscle stiffness in myotonic dystrophy or paramyotonica congenita. And drugs, which has already been talked about, associated signs and symptoms are also should also need to be looked along with muscle weaknesses. So if the patient is presenting with CCF, so muscular dystrophies like Duchenne and Becker's muscular dystrophy or Emery-Dreifuss have this associated symptom, and also the acid maltase deficiency can also present with CCF and cardiomegaly.
I think we are running out of time. Can we cut short at this?
Dr.
Yes,
Sabi,
sir,
your
yes.
time is off. Yeah.
So all these things are already been shown. Also the family history, because there are different patterns of inheritance, X-links, Duchenne and Becker, autosomal dominance, which is facioscapular humeral limb girdle, autosomal recessive, metabolic myopathies, and maternal transmission is seen in mitochondrial myopathies. So if we go for clinical features, then we can differentiate between different types of congenital myopathies also. So facial weakness will be present in Emmett rod and myopathies, and other differentials for it will be congenital myasthenic syndromes. So all these different clinical features have already
Dr. Zabi, you need to
can be
wind up
differentiated
now.
with, for example, bulbar weakness. Yes, sir. So this is clinical clues suggestive of specific diagnosis for an older child. So scoliosis, and these all are present in different types of congenital myopathies. Along with this, cardiomyopathy may be present in Pompe's or other type of these things. So, so that was my presentation. Thank you.
Okay. Thank you, Dr. Zabi sir, for informative presentation. Now I will ask Dr. Lokesh Lingappa sir for his valuable guidance.
Yeah, I think he has covered it. And few of the time, the last speaker will be doing this one. Already people are logging out. Let the last speaker speak, and then we can have a talk together. I'll request the final speaker to just not to repeat what has already been told. In a lot of overlapping topics are there. I think some of the slides will be overlapping. You can skip those slides and make it concise, please. Thank you.
So, Dr. Shefali ma'am,
I
wants
agree
to
with Dr.
add-
Lokesh. No, I agree with Dr.
Should
Lokesh.
we-
Let the next person say, yeah, please. Yeah.
Okay, ma'am. Okay. So our today's last speaker is Dr. Anup Moruskar. Sir is pediatric neurologist from Kolhapur and director of Adi Child Neurology Center. His talk is on counseling of parents and relatives in muscular dystrophies. You can start with the presentation, Dr. Anup sir.
Yes, ma'am. Just a minute. Is it visible?
Yes.
So without being delayed, thanks for this opportunity. So genetic counseling. So first question, the relative generally asks for why this test and why this test is necessary and why how this genetic inherited disorders are transferred from or affected their child. So we'll start with the molecular genetic studies. The application of molecular genetic technique has resulted in enormous gain in the understanding of the molecular and pathophysiological basis of the hereditary neuromuscular diseases. So it helps to establish the diagnosis and then shortens the diagnostic odyssey by ruling out other diseases, alleviate the need for invasive and painful procedures, mitigate cost, improve the psychological impact on individual and family members, assist with family planning, guide the testing of relatives, and allow the individual to participate in research studies for their condition, help with disease management. Then it is transmitted as a inherited autosomal recessive disorder. If a child only inherits an altered version of the gene from one parent, they will become a carrier. If both parents carry an altered version of the gene that causes the condition in the child. Then next is autosomal dominant inheritance. Here it only needs to inherit one affected gene from parent. Then next is X-linked disorders. The X-linked disorder is caused by mutation in a gene on the X chromosome. Females are less likely to develop an X-linked condition. Female can still be affected the disease by the disorder, but the condition is usually less severe than when the gene alteration is present in an affected male. Then when we consider a muscle disorder, then it can be a muscular dystrophy, congenital myopathy, or it can be a congenital muscular dystrophy. Then first is a muscular dystrophy, Duchenne muscular dystrophy, which is the most common muscular dystrophy of the childhood. We have already seen details about the inheritance and other clinical features and everything. So we'll go directly to the most so it is a large proportion DMD cases are caused by the large exonic deletion or duplication. The MLPA which it should be a recommended first-line genetic test for a male child presenting with the classic phenotype of the DMD. Overall diagnostic yield is about 65 to 70%. And if the MLPA negative, further analysis is required for confirmation of the diagnosis. So muscle biopsy with histopathology and invasive procedure, which is an invasive procedure and does not identify the gene mutation. To detect this sequence variants, sequencing of the DMD gene has to be done, but it is expensive and time consuming with the conventional Sanger sequencing techniques. So next generation sequencing, which is available now, is faster and most cost effective. So this is the MLPA flowchart. So next is the congenital myopathy. So most congenital myopathy is present in childhood with a significant majority presenting in infants or neonates. The hallmark feature given skeletal muscle involvement or weakness. However, this weakness also present with respiratory and feeding difficulties. So these are the clinical presentation of the congenital myopathies, like presenting with craniofacial dysmorphism of myopathies with ptosis. So these are the congenital myopathies, Nemaline myopathy, centrinubular with the mode of inheritance, that Nemaline myopathy can be transferred from autosomal recessive or autosomal dominant. Centrinuclear myopathy can be X-linked recessive or autosomal dominant or autosomal recessive also. Like the genetic etiology for congenital myopathies. So we have to consider it like clinical clues, particularly suggestive of a specific diagnosis in congenital myopathies in newborn or infant less than 2 years of age. So these are the spectrum of genetics mutations where we can see a clinical features on left column, which present a facial weakness, ophthalmoplegia, ptosis, facial dysmorphism, and their differential diagnosis and respective mutation in genes. The same is in the older children, which present with scoliosis, rigid spine, cardiomyopathy, foot drop, or malignant hyperthermia. So we can differentiate according to proximal or distal weakness with the posterior, anterior, or mixed muscle of groups. Then distal myopathies can be autosomal dominant or autosomal recessive. In congenital myopathies, muscle biopsy is always not needed, given availability of next generation testing. May be important if the DNA test results are negative or report only variant of uncertain significance. Molecular testing for congenital myopathy and proceeding directly to genetic analysis in congenital myopathy usually not been practical. Nevertheless, going straight to specific genetic testing has been used in the following circumstances to exclude an alternative diagnosis, for example, severe spinal muscular atrophy or congenital myotonic dystrophy. What to do when a severely ill neonate comes? So in the rare cases where there is a severely ill neonate in whom a congenital myopathy is possibility, a genetic testing for X-linked disorder or like centronuclear myotubular or congenital myotonic dystrophy or congenital severe Nemaline myopathy may be appropriate if a biopsy cannot be obtained ante-mortem. It is an important in these circumstances to collect muscle biopsy, blood for DNA, and to establish a fibroblast cell line immediately after death. Next is a congenital muscular dystrophy. Here the present early in life during infancy or soon after birth, present with hypotonia, having contractures like ankle, hips, knees, on elbows, and breathing difficulties. So these are the main CMD types, with MDC1A with a merosin deficiency, MDC1B, which present with respiratory insufficiency, spinal rigidity, and weakness in less progressive. Collagen type 6 rich CMD severe, which is present with severe features, and Bethlehem CMD, which is a milder one. This is the alpha dystroglycanopathies, which are present with their clinical features and spectrum of the genetic mutation. This is the NGS panel for associated gene included in the clinical. So the interpretation of the results. So when the patient comes and asks for a explanation of the result, the first result, there are more, mainly three possibilities of the result that can receive from a genetic report. First is a positive result. A positive result means that testing has identified a gene change or genetic mutation in one or more of the genes analyzed. This type of result may be called a pathogenic or disease causing variant. It could lead to change in the management of healthcare. Biological family members may wish to consider genetic testing to better assess their own risk of also having the variant, as these changes often runs in families. Then the negative results. Genetic testing results usually may also be negative. A negative result means that no gene were identified in the gene analyzed, while negative result meaning no genetic condition or risk was identified is often reassuring. It typically cannot rule out a genetic condition, as there may be undiscovered gene or variant that were not included in the test. Then third one is the uncertain result. This is that one or more variants were found. However, it's unclear whether those variants could be contributing to a disease or disease risk, or if they just a normal part of a human genetic variation. Uncertain results are relatively common, especially when a large number of genes are analyzed. Most of the time, and uncertain results wouldn't lead to change in the medical care. It might recommend additional testing of family members to help clarify uncertain result. Over time, uncertain results may be changed to a positive or negative once more information is known. Then the recurrence risk for future pregnancies. So we can differentiate on the basis of pattern of inheritance like autosomal dominant. An affected person has a 50% chances of passing the trait to the child. Males and females are equally likely to be affected, and two affected people can have an unaffected child. Then autosomal recessive inheritance, an affected individual has two parents who are unaffected, but each parent carries the altered gene. Males and females are at equal risk for being affected, and two affected individuals usually produce children, all of whom are affected as well. Then X-linked dominant. In X-linked dominant, all daughters of a male who has the trait will also have the trait. There is no male-to-male transmission. The trait follows the inheritance of the X chromosome. Sons can have the trait only if the mothers also have a trait. Then the X-linked recessive. The marriage between a male with an X-linked recessive trait and an unaffected woman produces children with one of the two genotypes. All of the daughters are heterozygous carrier. They do not show the trait but can pass it along their sons. Then prenatal diagnosis. Prenatal diagnosis for the families at risk is recommended in disease carrier and non-carrier parents of the affected child. The sampling method for prenatal diagnosis include chorionic villus sampling performed after 11 gestational week and amniocentesis along with chordiocentesis. Chorionic villus sampling is preferable as in a case of potential pregnancy termination. The earlier the procedure is performed, the lower the risk for the patient and the burden for their parents. The invasive prenatal procedure are associated with an estimated of 0.5 to 1% of risk of pregnancy loss. Even if severe abnormalities are detected on ultrasound, detailed genetic testing is typically restricted to the postmortem period. Targeted diagnosis in the prenatal setting comprises next generation sequencing assay or ACGS panel for the detection of copy number. Karyotyping by ACGS and whole exome and whole genome sequencing enables rapid identification of causative genetic defects in majority of cases. Then gene targeted therapy. After receiving a diagnosis from a genetic test, it may be able to direct to gene targeted therapies that can symptoms that can keep symptoms from worsening or prevent them from occurring at all. Conventional medications for neuromuscular disease are mainly used to help manage symptoms or try to slow down their progress, but these medication will not eliminate symptoms or stop them from progressing. Gene targeted therapies hold great promises because they seek to fix the underlying cause of a genetic disorder. There are different types of gene targeted therapies being studied and developed. Currently, targeted therapies that replace or alter the expression of genes or enzymes are available for several neuromuscular disorders like Pompe spinal muscular or TTR amyloidosis. And clinical trials are ongoing for therapies to treat certain genetic types of many different neuromuscular disorders. So the take-home message. In muscular dystrophies, first-line genetic investigation should be MLPA followed by MGS if MLPA is inconclusive. Direct genetic testing or analysis congenital myopathy is not advisable. In congenital myopathy, muscle biopsy is needed if next generation DNA testing is negative. In severely ill neonate muscle biopsy, blood for DNA should be collected immediately after birth. In addition, additional testing for family members should be advised in variant of uncertain significance. Different types of gene-targeted therapies are available for several neuromuscular conditions, and multiple trials are going on. So these are the references. Thank you.
Thank you, sir. For such a nice presentation. Now I will request for valuable Dr. Lokesh Lingappa sir for guidance, for valuable guidance. Sir, is there?
I think sir is not there. Shefali ma'am, please guide.
Yeah, I think it has been very rightly covered. So we have to understand that we have to try to take a history and then have a focused examination and try to plan out what investigations to do. And it is not as a, you can't just get whole exome sequencing done in any patient walking into your room, because sometimes, you will not get, you have to do specific investigations as we have talked about the MLPA things in SMA. And if the MLPA doesn't come, then you go ahead, in that you go ahead and do a SMA. We didn't discuss about this part that we have to do an SMA targeted sequencing. And only if you're suspecting SMA. And if you're not suspecting SMA and you have no other evidence, then you go for exome, because SMA area is not very well covered in that way. And for DMD, we discussed that MLPA, yes. And if it is negative, then you do an exome. In the exome will give you all the nonsense mutations and all that. And yes, congenital myopathies and CMDs, there's an overlap. You have a lot of genetics which has come up, and their genetics, a lot of genetics come up with the peripheral, the neuropathies, which are the congenital muscle, the congenital neuropathies, which they are. So they are, you have so many, all this Charcot-Marie tooth variants and all, and many of them, so you have genetics coming up. But what we have to remember is you never forget the history, never forget the family history, and try to get a diagnosis. If you have a very sick child, you please try to take the samples. You may not, and sometimes those a critically sick child, you please try to take all the samples and keep, at least you keep for genetic testing as well. And any other, if you're metabolic suspecting, you should keep the relevant samples. What I mean is you may not get time, and our duty is to do the best what you can for this particular child, and also have a diagnosis who has to counsel the family. And that is very important, because having multiple effective SIBs in the family, I think, is a failure of the medical fraternity. So that is important. And other thing is, don't forget that multidisciplinary supportive care is important for all neuromuscular diseases, and we should be giving that, and that includes DMD with steroids. It's included as a standard of care, and other supportive things. And you have newer things which have come up. We didn't have talk about SMA. We did talk a little bit of DMD, SMA. You have the gene therapy, and which is approved for less than 2 years, and you have trials which we are undertaking, which one we are also site for more than 2 years intrathecal, and you have 2 other drugs which are there, which are helping SMA. Actually, it was not a point of discussion, but just for you to understand that you have SMN1 and SMN2. SMN2 is a backup gene of the SMN. So the SMN1, you see that it is absent, and then you see SMN2 copy numbers when you're doing the MLPs, because depending on the copy number you have of SMN2, you're going to be able to have a benefit on other therapy. What happens is SMN2 and SMN1 में सिर्फ C2T का change है, एक base pair change है only, पर वो base pair change होने से SMN2 में you have an exteriorization of the exon 7. That is why you don't get a very good functional protein. When what we are doing by giving by the Evrysdi, which is there, right, and the risdiplam, as well as by the Spinraza, nusinersen, what we are doing is we are ensuring they are splicing modifier ताकि जो exon 7 exteriorize हो रहा है वो exteriorize ना हो, so that you get a more functional protein. That is how you are acting. So these are important to understand, and these all the SMA side is better off results coming off, and for them for these newer therapies. But your supportive care has to continue, but their outcomes are better, their motor milestones are much better. But the earlier you pick up, and it is shown that in less than 6 weeks, if you pick up and do, then they get nearly age appropriate milestones by WHO. पर वो 6 weeks से पहले पता तो चलेगा नहीं ना, तो वो तो newborn screening के लिए SMA के लिए बोल रहे हैं, DMD के लिए अभी newborn screening के लिए नहीं. Somebody did mention, but DMD needs for SMA. So I think it's important, and you have to counsel the family, tell them about the prenatal diagnosis, and the genetic counseling is not simple, it is complicated. So you have to have a good diagnosis, and you are not going to dictate to parents what to do. You have to give them options, and you have to tell them the risk. So it is and should be sent to a geneticist. And if you don't have by simple clear cut, you can do also. But point is important is that it is not that if you have a second child who's affected, it's our failure. I think we have to work together, and there should be a licensing between the pediatricians and the pediatric neurologists. And as president of Association of Child Neurology India, I was trying to do that, that we can have some kind of a network, referral network in your local areas, and where you can refer patients which are smoothly, and they come back to you. And if there is a good diagnosis, you are party to the publication. Thank you so much. It was very enriching, listening to 5 wonderful presentations. Family को ना coping strategies बतानी है before they have a, you have to tell, and कोई और नहीं बताएगा. Pediatrician जो देख रहा है या pediatric neurologist जो देख रहा है वही बताएगा. हमारे पास कोई social worker होते नहीं है. So we have to tell and guide the parents what they have in store for them. And you may take 1 or 2 meetings before you tell, but it's our responsibility. I think that is very important. Besides telling them key genetic counseling and prenatal diagnosis, coping strategies, and providing the supportive care. There are a lot of parent support groups which are there, so unke saath you should get them associated. Thank you.
Yeah.
Eco.
Yes.
Neha.
Neha,
Neha, take over.
Yes, I think so. Now everyone is waiting for my vote of thanks.
Yes, ma'am. I was requesting for you that only.
Thank you, Swati. The topic chosen was very interesting today. Friends, you all know that muscles are unique tissues that contract and relax on order of the brain, whereas in some cases they decide not to comply, using causing stiffness or laxity, that is hypotonia. Many of these inherited myopathies have no cure. But before arriving to any diagnosis, yes, we should first be able to differentiate between different causes of muscle weakness and hypotonia. Caring for such children is a huge challenge. It's a bigger challenge for doctors to counsel their parents and relatives about the longevity and quality of life of their child and probability of disease in ensuing pregnancies. A simplistic explanation of genetic basis of the disease will definitely prepare them for the care of this child and further progeny. So today we had a superb session on various muscular myopathies and dystrophies. I would like to specially thank our respected Dr. Professor Shefali Gulati ma'am and Lokesh Lingappa sir for accepting our invitation for being the expert for today's Tuesday Take program. Their superb guidance and expertise comments really was very informative. I would like to thank MAHAP President Dr. Ramakant Patil sir and our Secretary General Dr. Amol Pawar sir for giving their support and MAHAP platform. I thank Maharashtra Medical Council and our MMC observer for today, Dr. Suhas Patil sir, for joining and giving us one MMC point. I thank all the 5 speakers, Dr. Jagruti, Dr. Nikhil, Dr. Pankaj, Dr. Zabikha, and Dr. Anu for preparing and delivering their topics fantastically. Would like to thank Women's Committee Chairperson Sonali Shirvate ma'am, our convener Manjusha Shelkar, as well as other members of Women's Committee for helping in organizing today's program. I like to appreciate and thank Dr. Swati Patil as my partner in moderating the program. Thank you, Pallavi ma'am, for being always there and solving the technical issues. Last not the least, all the attendees on Zoom as well as YouTube Live for joining us. Requesting everyone to please join our next Tuesday take on 17th October. Thank you so much and good night.